Good afternoon, everyone. I'm Dr. Faisal Khan, CEO of the Houston Medical Flagship. We have today Unab. He is an aspiring student from Jamshoro, graduated from LUMS Pakistan, and want to pursue a neurological career. And we'll be listening to him about the Moya Moya disease today. So, welcome aboard, Dr. Unab.
Thank you, Dr. Khan, for that introduction. And I'll start with my presentation. Today we're going to cover the basic aspects and dig deeper into the mystery that is Moya Moya disease. Okay, let's start. Okay, so Moya Moya disease was given this name by a Japanese scientist. It means hazy puff of smoke. Now, why it is named that? Because when there is occlusion of the vessels, the collaterals will form, and on MRA it will look like somebody have given out a puff of smoke. That's why it was named that. Usually the occlusion occurs in the internal carotid arteries bilaterally, but it can also involve the proximal portions of anterior cerebral and middle cerebral artery. Now we need to distinguish whether it is Moya Moya disease or Moya Moya syndrome. The way we distinguish is pretty easy. If it is associated with an underlying condition, either an infection, metabolic disease, genetic disease, it is a Moya Moya syndrome. But if it is only an isolated thing, like isolated occlusion, that's idiopathic, that's Moya Moya disease. Let's move forward. Okay, so Moya Moya disease preferentially affects East Asians, usually from Japan and North Korea, but it can also involve other entities as well. But these demographics are usually the one most affected, with South Korea having 16.1 per 100,000 individuals prevalence, and Japan of 10.5 per 100,000. In United States, the trends are going upward by the years, and about 0.09 per 10,000 incidences reported in the United States, which is a lot if we see about 10 years back. Okay, so this is a big slide. There are many. This is how we differentiate between Moya Moya disease and Moya Moya syndrome. This Moya Moya disease, first, it's usually idiopathic because there is no underlying condition which is causing it. So there are some genetic associations that we have found. The major one is RNF213 gene mutation, and it's usually seen in Eastern Asian populations. That's why it preferentially affects those demographics. There is also recently another mutation found on locus 17q25, which is associated with white matter hyperintensities, a pathognomic feature of Moya Moya disease. Then we have some novel risk focus seen on MRAs in these patients which have homocysteine metabolism regulation gene mutations and large vessel disease associated focuses. Now this is pretty standard for a Moya Moya disease primary thing. For the secondary one, there's a whole list to it. There are certain etiologies, first diseases that affect the circle of Willis, usually the big ones, atherosclerosis, the patient had radiation history, trauma, brain tumors, even infections such as meningitis, hematologic conditions, sickle cell, beta thalassemia, anemias. Now usually these are all prothrombotic conditions. Because this will increase the stroke, already the patient is at an increased stroke due to Moya Moya disease, this will also increase the risk further for them having a stroke, because these are all prothrombotic, like factor 13 deficiency, essential thrombocytopenia, protein S deficiency. If you go to the genetic disorder, there is a long list: Alagille syndrome, Down syndrome, hypomelanosis, ITO, Marfan's, neurofibromatosis type 1, Noonan's. Usually the ones we see are neurofibromatosis type 1, sickle cell disease, and Noonan syndrome. These are majorly the ones that these patients get affected by Moya Moya also. If we move toward the vasculitis, SLE is the big one. Then we have polyarteritis nodosa, Graves' disease. Usually the thyroiditis is associated with pediatric MMS, like pediatric Moya Moya disease, and thyroiditis associated with that. Then we have antiphospholipid, angioedema Sjogren's type 1, and pulmonary sarcoidosis. If we go further, we have vasculopathies, coaptation, congenital heart disease, renal artery stenosis, metabolic type 1, which is von Gierk's. Von Gierk's is basically the deficiency of glucose 6-phosphatase. The glycogen can't break down, so it's accumulated in liver, kidney, and all this bones and stuff. So that's that. Then we have hyperphosphatemia and primary oxidosis. renal disorder, polycystic, and LUMS tumor, which is a pediatric renal cell tumor. Okay. Now, this is the biochemical pathogenesis of Moya Moya that so far we know. As you can see, there are big 2 question marks here. That means we still can't say for certain that whether these are involved in it or not, but they are associated with it in a certain way. First of all, we have securins and microRNAs. Now, securins, basically, they inhibit the aberrant generation of vessels after a stroke. So if securin levels are decreased, that means the aberrant pathogenesis would increase in those patients. Same with microRNAs. They involve in development, proliferation of cells, and also cell aging. Then we have dysfunctional endothelial progenitor cells and smooth progenitor cells. Because as we will learn in the next slide, that the main pathogenesis of Moya Moya is it causes intimal hyperplasia in the arterial lumen. This intimal hyperplasia has 2 major cells involved. That's the endothelial and the smooth muscle. First, the lumen will become smaller, then the outer diameter of the whole vessel will become smaller. So these 2 cells play a major role in that. Then we come to the caveolin. Caveolin are basically plasma membrane invaginations. When they go berserk, like their levels are decreased, the capillary formation is interrupted. So if there is a stroke, the collateral vessels usually don't form as much as we need in infarction areas. Then we come to the CRAP-P1 protein. It is also associated with growth factor like VEGF, vascular endothelial growth factor receptors and all that stuff, and retinoic acid receptor also. So this is also involved in the proliferation and the angiogenesis process. All these factors, along with environmental factors such as autoimmune inflammation, as we discussed in pediatric Moya Moya, autoimmune diseases are usually associated with this disease. So all these factors combine and they cause vascular stenosis and aberrant angiogenesis. Okay. Now this is the picture. This is basically where through the microscope seeing what happens in the vessel. First, A and D are normal images. As you can see, the lumen is normal, the outer diameter is normal. Here there is no intimal proliferation, the red blood cells are flowing properly. Then we come to the early stages of the Moya Moya disease. As you can see, the lumen here is a bit decreased. The blood is pooling outside of the stenosis, and this is the intimal proliferation. It's starting to narrow the lumen. As we move forward to the late stage, you can see the lumen is almost completely obstructed, and the intimal hyperplasia is out of control, and it is completely occluding the lumen of the vessel. Now, most Moya Moya disease, as we discussed, usually occurs in the ICA. It can involve the ACA and also the MCA, proximal portions of them. But interestingly, the posterior circulation is spared in most Moya Moya patients. And if it is involved in those patients, it is a negative prognostic indicator. And also, when it is involved, it only usually involves the posterior communicating artery and the P2 segment of the PCA. It spares the basilar artery and the P1 segment. Now, these are the 6 stages of the Moya Moya disease. Firstly, only internal carotid artery stenosis would be seen. No collaterals would be seen on MRA or any of the imaging. Then, the second stage, the collaterals would begin to form. Third stage, the prominence would be seen on these testing. We could see the hazy puff of smoke appearance in the third stage. Then we come, there is severe stenosis as it is progressing at a faster rate, usually involving the circle of Willis. Moya Moya vessels begin to narrow more and more, and even extracranial collaterals begin to form to accommodate for that increased stenosis. Then we have prominence of those collaterals even, and we can even see on imaging, and then there is complete carotid occlusion. Usually it's the last stage, and the patient doesn't move forward with that anymore. This is, as it is a vasculopathogenic disease, the most common presenting symptoms is a stroke. Even in strokes, the most common presenting stroke is an ischemic stroke. It can cause TIAs also with the same occurrence as an ischemic stroke, but hemorrhage is decreased in occurrence as compared to those. Then less commonly can also present with seizures and headache, and that presents an interesting dilemma, because usually headache is not considered a malignant symptom. It can occur in a variety of diseases. So neurologists and neurosurgeons can miss this disease because it's not that common, But the only presenting symptom usually in pediatric patient is headache. So the MMD should be on the differential of neurologist mind. Then we come to the rare, such as choreiform movements and cognitive psychiatric changes could also appear. Now these are the associated conditions as we discussed before. As you can see, usually the angiographic findings of Moya Moya without any other disease are seen, and Asian heritage is common in that. As we discussed, East Asians are the most affected demographic. Less commonly, these are the symptoms that is associated with the Moya Moya syndrome, sickle cell neurofibromatosis, irradiation of the cranium, and Down syndrome. Rarely it could also be associated with congenital cardiac anomaly or renal artery stenosis. But those those population are less as compared to others. This is the imaging that we see in Moya Moya as usual. Now A is the normal. As you can see, every artery, every branch is patterned. It's taking up the dye. And we move down, this is the hazy puff smoke appearance. As you can see, the collaterals are starting to form at the points of obstruction. If we move further, this is the collaterals that we see on T1 image. This is T1 MRI. This is the T2 MRI. You can see the collaterals are forming in this region. And it's E, you can see the IV sign appear at this. What is IV sign appearance? IV sign is basically the formation of collaterals on the surface or on the exactly on the boundary of the gyri. So you could see as this white shadow that is appearing here. That's the idea, and it's kind of pathognomic for Moya Moya disease, because collaterals are so common in these patients because risk of stroke is increasing these. This is another image. Now this is basically all the tests that there's a comprehensive panel of tests that we do for Moya Moya disease, and it includes a luminal angiography, vessel imaging, MRIs, and other stuff. And also the big one, that is bold CVR, that is bold cerebrovascular reactivity that we do for it. Now the first one, as you can see, this is a bypass stent that is made with superficial temporal artery. Because this patient had the disease of Moya Moya, he underwent bypass surgery, and usually the superficial temporal artery is used for that. So this patient has undergone that procedure. And you can see here, the internal carotid arteries are narrowed in this bilaterally. Now if we move to the other one, in the B image, we can see this collaterals form here in this image. Here we can also see the white shadow that is forming. This is also signifying the appearance of collaterals, and also the other this arrow too. If we come here, as you can see these dots signify that these are the areas of stroke, and here new vessel formation, new vascularization has occurred. We come to this is the pattern dynamic, this is known as dynamic contrast pattern. Basically what we do in this, we give the contrast concomitantly or simultaneously we image the patient. Gadolinium contrast is used, a bolus is given, and we image the brain directly with that. This is another image showing TTP. Now CBF means cerebral blood flow. Here the blood flow pattern is showing, which is pretty normal. Here the TTP is time to peak. Now these are terms which are used in DSC imaging. Time to peak, cerebral blood flow, Tmax, these are all that now the blood flow is at peak, it has reached its maximum, cerebral blood flow pattern is showing. Now this last one is a bit peculiar for this. Bold CVR, and what we do is basically we introduce a stimulus, a test rhythm. We ask the patient to hold their breath for 20 seconds, and we see the cerebral reactivity that occurs here. Bold basically stands for oxygen levels and cerebrovascular reactivity. What happens as the pathogenesis states that there is an occlusion, the vessels, when it's a normal adaptation of our body, when there is an occlusion, the vessels will dilate the farthest they can. Now in brain, we all know the major regulator of blood flow is carbon dioxide. And it is also said that in pediatric patient, hyperventilation is a trigger for Moya Moya. What it means, when we hyperventilate, the carbon dioxide moves out. Carbon dioxide decreases, those maximally dilated arterioles become constricted because the main regulator has moved out, the carbon dioxide levels have decreased. So it can trigger an episode, trigger a stroke in pediatric Moya Moya patients. In this, what happens, the stenotic vessels are already maximally dilated. If we ask the patient to hold the breath, this doesn't change as much because they are already maximally dilated. They can't dilate further with the carbon dioxide levels. So we see no change, and this blue pattern is usually seen with steel. The stenotic vessels steal the blood out of earth, and these are undergoing hypoxia or ischemic changes. So this is a pretty interesting test that we usually do for Moya Moya patients. Now this is the treatment plan. As we discussed, there is a comprehensive imaging panel that we have to do. Also, there are a lot of blood tests they have to do because it is associated with so many diseases. And first thing we have to do is diagnose between Moya Moya syndrome and Moya Moya disease. So blood tests and imaging will tell us whether it is MMD or MMS, associated underlying condition. Then if it is MMS, we usually go for the treatment of underlying condition along with neurosurgical consult. But if it is MMD, usually the first person they go to is neurosurgery, and then it is seen whether there is an ischemia or hemorrhage. If there is an ischemia, then we directly go for revascularization. We will discuss the types of this revascularization in the next slide. But if there is no ischemia or hemorrhage, we see if the patient has impaired cerebrovascular reactivity. If no, then we go for maximal medical therapy for stroke prevention. That is our aspirin, all the secondary stroke prevention stuff that we give. If there is impaired CVR, both will go for revascularization. After revascularization, the patient needs to have CTA within 24 hours, whether the graft that the surgeon has put in is patent or not. Then the follow-up should be done with an MRI protocol at 3, 12, and 24 months. That's the protocol that we follow for Moya Moya patients. Now, there are basically two major revascularization types that we use. There is a direct one, and indirect one is exactly as the name suggests. Direct means we directly put a graft, we connect, do an anastomosis between the stenotic artery and a patent artery, so the blood flow can go to the ischemic areas. That's usually, this is the superior method. This has more good prognosis than the indirect method and the maximal medical therapy method. Usually it has decreased post-operative cerebral events and improved hemodynamic status in the patients. Now, indirect revascularization is a bit peculiar. We usually do not create a direct anastomosis in this method because this is indirect. What we do is we put the donor artery directly on the pile surface of the brain. And then the idea is that over time it will begin to form the collaterals and it will provide the blood flow to the ischemic areas underneath. Usually the direct revascularization method is done, but there is a method in which both can involve. Thank you.